All right, everyone. Thanks for joining us. We've reached the half-hour mark, so we'll go ahead and get started. I'd like to welcome everyone to this week's installment of the AMSSM's National Fellows Online Lecture Series, sponsored by AMSSM Fellows Online Education Subcommittee, which is part of the Education Committee and the Fellowship Committee. I'm Alberto Oseguera. I'm an assistant professor in family medicine and sports medicine here at UT Health San Antonio. Um, Tonight, we have the great pleasure of hearing from Dr. Josh Gellert regarding the use of evidence-based rehab modalities. Dr. Gellert is a physical therapist and board-certified sports specialist at the Sports Medicine Center at the University of Washington. His focus is the post-operative rehabilitation of injured athletes, sports trauma, adolescent sports injuries, and rotational athletes. He strives to create active partnerships with his patients to achieve the best possible outcomes. He earned his doctorate of physical therapy from NYU. His clinical interests include post-surgical rehab of the knee, shoulder, hip, foot, and spine, non-operative sports trauma, adolescent sports injuries, rotational athletes, and prevention of ACL injuries. His research interests include rehab and prevention of hamstring injuries, rehabilitation of the non-arthritic hip, rehabilitation and post-surgical outcomes of ACL and rotator cuff injuries, as well as concussion management. Before we get into our topic for tonight, I just want to remind everyone of next week's lecture. We'll be having a great lecture about the care for the diabetic athlete, which will be given by Dr. Valerie Cothran 1 week from today at the same time. I'd also like to mention the goals for today's lecture, which are to adjunct your home program's educational content, as well as provide fellows with direct access to educational experiences with AMSSM members and at times invited guest experts like today, as well as assist in our CAQ exam preparation. Some general housekeeping rules. Please mute your device's microphone and turn off your video. You can submit questions through the chat function. I will go ahead and comb through those, and I'll ask the questions at the end during our Q&A session, as well as please don't forget to complete the evaluation at the end of the lecture. One of our new efforts is to facilitate more input from our audience. There's a couple ways to do that. First, there is a web link that can be found if you go to amsssm.org. If you click the Education tab and then select Fellow Online Lecture Series, there's a link towards the top of the page as seen here in the screenshot. You can also use this QR code and it should take you directly to the form to fill it out. While filling out the form, we ask that you please keep in mind that the primary goal of this series is to assist in CAQ preparation for the fellows. So without further ado, I'd like to welcome Dr. Josh Gellert.
All right, good deal. Well, my name is Joshua Gellert, and it's just a distinct honor to be able to give this talk today on evidence-based rehab modalities. The intentions of today's talk is to review the evidence behind the rehab modalities that we kind of commonly use in practice, review the evidence behind those treatments, specifically for MSK pathologies, and understand when to best implement each treatment modality or biophysical agent. So my invitation for you to get the most out of today is to be curious, to observe with intention, and ultimately to leave with new skills. I want you to be able to leave today's talk with a better understanding of the implementation of these modalities and ultimately how to best help serve your patients in your greater community. So just a quick background, I presently work at the sports medicine clinic at Husky Stadium. I'm a sports certified specialist, but really my distinct honor is that I am able to precept both the Family Med R1, R3s, as well as the fellows, and really being able to cultivate those relationships over the last almost 11 years now that I've been at UW. It's just been wonderful just to see the fellows just come through and just see them do really great things within their career. So again, I'm at the Sports Medicine Center in Husky Stadium within the football stadium. And when patients come in to see me, ultimately, they don't know what I do. So let me take a moment just to give you my quick elevator pitch. And it's like, well, you know, I'm a movement specialist, and my job is to help patients move and feel better. It's my job to help facilitate a partnership between you as the doctors and the patients themselves to move better. And in order to do that, we utilize modalities. But here's my disclaimer: the New York Times wrote a great article, a few years ago, essentially saying what we've all known is that not all physical therapists are the same, but those who value evidence over anecdote, are essentially the best practice. However, within the same article, what's relevant for today's talk is that they characterize the modalities that we utilize as voodoo treatments, and the goal for today's talk is to kind of go through and debunk, what those voodoo treatments are, and to provide, an intention and a better understanding as to what that is. So when we're talking about treatment modalities, what are we really talking about? Well, they're external treatments that help to reduce pain and inflammation, improve range of motion, and ultimately support tissue healing. And they help to bridge the gap specifically from pain to performance, and utilizing that to help promote strength, endurance, and performance at various stages of a rehabilitation journey. Some examples of these, can be things like cryotherapy, laser therapy, blood flow restriction therapy, TENS, ultrasound, and we're going to go through these uh, individually throughout today's talk. But I won't have time to go through every single one. So my goal is to be able to touch the ones that are perhaps the most relevant, the ones that I'm seeing patients come in with the majority of questions with recently, and to be able to dive through that evidence, as well as answer questions that I'm hearing doctors and the fellows ask me around specific modalities. So that way we can kind of have this big capture net and kind of be able to narrow it down within the intention of this, 45-minute talk. But ultimately, you can think about these external treatment modalities as being broken up into 4 different categories. Are we administering thermal, mechanical, electromagnetic, or light energies to facilitate a healing process? And Phil Page did a great article on IJSPT the last year, basically sharing that, well, it's not modalities. It's not a therapeutic modality. That got a really bad brand when there were some therapists that were just putting on heat and ice and then just like overbilling Medicare. And now modalities are no longer a reimbursable unit. So part of that is being driven from an insurance standpoint to rebrand, but also to specifically clarify what the modalities are doing. And they're biophysical agents, right? They are non-pharmaceutical short-term pain relief to help patients achieve their goal. And their intended use has a multitude of intentions, but ultimately it kind of boils down to decreasing pain by reducing or eliminating edema, improving circulation, decreasing inflammation, and working on various levels of tissue. So when do we utilize this? Well, when somebody is working out, there's this natural, stress response cycle. And within that kind of first 48-hour window after load, you're going to have a reduced capacity to then be able to load more. So utilizing these from a performance standpoint on one edge of the spectrum, modalities can best be utilized here. And we'll go through what those are one by one in a little bit. But we can continue to utilize that as that cycle increases. But also what I want to recognize is that, hey, if somebody's in pain here, then they're just going to continue to have reduced capacity. And that's where the modalities and the intention of providing that short-term pain relief can be really effective, right? So we can utilize it as an adjunct to the traditional like strength rehab and performance training, just like what I shared in that last graph. And a good example of this would be like, hey, if somebody's coming in with low back pain, they're really hot, they're really lit up, they don't know, what to do, they don't know what movements to utilize. As an example, we could apply heat and a TENS unit, and that's been associated with improvement in short-term goals. It has also been associated with better outcomes within that population. Additionally, Katz et al. Reported that direct access to PT with modalities reduce the odds for short-term and long-term use of opiates in low back pain. So just two specific examples of when we can utilize this on the front side of things and the benefits of it, but that extrapolates out as well as far as early stage ACL, shoulder dislocations, ankle sprains, regardless of the body part. And how I like to think about this is that we're utilizing these biophysical agents for short-term pain relief, just like how you might utilize pain medications for the same short-term pain relief. It's just the difference between a pharmacological or a non-pharmacological agent. They can work in tandem. The multimodality approach of that, it can certainly be significantly more effective than that in and of itself. So alongside that, though, it's not intended for long-term use. So the utilization of modalities and biophysical agents is not, to be utilized throughout an entire rehab process, or even perhaps like along like the longevity of somebody, but truly understanding the intentions and the sweet spot of utilization of each one, much like how you would understand of like when to utilize your anti-inflammatories in the whole scale of spectrum, perhaps like how you would utilize Toradol versus like a cortisone injection, can really provide more precise and effective care for patients. So within that same page article, he went through kind of like each body part one by one and assessed treatments, strategies that were being used as far as modalities go, and if the literature recommended it or not. Then in that far right side of the column, what percentage of therapists were reporting use? And what was really striking to me was that like, hey, like for the example of like laser and neck, like if we're saying that the literature certainly supports this, but only 6% of therapists are utilizing this, that's a 94% of patient capture that's having a disservice. And part of that is, like these modalities, these biophysical agents require equipment. So part of it could be bad. But the other part of it could be perhaps that, hey, like maybe as the treatment algorithm is changing for best practice of treatment, as does the need for these biophysical agents to also change and evolve within the patient population. So we're going to go through the mechanism of actions of these biophysical agents. And again, the intention is to provide that acute short-term pain relief through both direct and indirect mechanisms. And we can utilize these at different stages of healing, inflammation, repair, and remodel stages. But again, on the other side of the spectrum, we can utilize it from a rehabilitation and in a recovery and a performance setting. So when we're saying a direct mechanism of pain relief, what we're speaking of is a modulation of inflammatory mediators, specifically slowing down nerve conduction, blocking pain signals, the analgesia effect from from releasing your endorphins, stimulating the muscle, and wound healing, versus the indirect mechanism of spasm of pain relief through spasm reduction, through tissue healing, and perhaps more like global blood flow, the global aspect of lymphatic drainage and metabolic exchange. But the other factors that we need to consider are placebo effect, your therapeutic effect, and the natural healing timeline of your tissue. And honoring the fact that hey, like placebo is really powerful. Placebo works about half of the time. So the fact that a patient or a client is feeling like they're getting something is powerful in and of itself. The therapeutic effect of what we're working on at the tissue with each biophysical agent, as well as the natural healing timeline. Like what is the normal inflammatory cycle of tissue itself? What is that inflammatory cascade, naturally going to do? And the combination between all of these three things are going to impact the overall pain relief of the patient with that specific pathology. And we all know that that pain has a multitude of influences. And if we look at this biopsychosocial model, like there's so many different aspects that are there that we want the biophysical agents to be able to cut through that noise as quickly as possible. But a lot of times, like patients are coming in with a thread bucket, and I apologize, that's not blood, that should be water. They didn't couldn't find a picture with that as water. So just imagine that as blue. But ultimately just kind of thinking like, hey, how full or empty is that bucket on any one day or time? And when a patient's coming in pain, it's going to be higher. So anything else that we can do to help them feel more comfortable and less of that sympathetic fight or flight state, then perhaps the more they're going to be able to tolerate other threats or pain influences within their lives. And the way that we're addressing this is through different pathway systems of the biophysical agents, both through ascending pathways and descending pathways. And the ascending pathways are essentially you're utilizing one of these biophysical agents, and the pain signals in the peripherally in the PNS are blocked at the spinal cord level. So they're getting blocked on the way up. Examples like that could be a hot, cold, or laser from a thermal standpoint, or perhaps electrical modalities like TENS or neuromuscular electric stimulation. The gate theory of pain is essentially the larger theory behind all of this, where essentially it's getting blocked at both the A delta nerve fibers and the A beta, like essentially like your larger or your not as large nerve fibers. But the descending pathways are what I find really quite interesting, because you're essentially inhibiting your pain at the central nervous system, and it's getting blocked essentially at the spinal cord level, going down to the periphery. And some examples of this would be diffuse noxious inhibitory control, or essentially that hurts so good treatment, where like if you're foam rolling or like cupping or like Graston techniques, where it's like, oh wow, like man, like that hurt, but it was a good kind of hurt, not like a tissue damage kind of hurt. Well, you're actually providing your sensory cortex with some other information outside of pain, which then it's able to kind of process and descend from the central nervous system into the periphery. Where I find this most interesting, again, as my job as a movement specialist, is understanding right the movement pathways of the brain and of the body. And when I'm looking at these pathways and being like, oh, these ascending and descending pathways, well, that's directly going to impact the motor cortex and how the motor cortex communicates with smooth, coordinated, precise, and accurate movement time and time again, which is what my athletes need to do in order to perform. So in the presence of pain, right, your brain isn't necessarily processing things as eloquently within the motor cortex, as we process information bottom to top, the old brain to the new brain, and then back to front. So the sensory cortex before it reaches the motor cortex, right? Bottom to top, back to front. And in the presence of pain, right, we're getting stuck in that old brain, and then it's kind of getting reflected and refracted like back down versus the new brain, and understanding that that really precise and accurate movement is occurring there. So what can we do to kind of bypass this gatekeeper is the intention of the majority of these modalities. So again, when we're talking about this ideal versus not ideal situation, it essentially comes into like just being Tom Cruise versus Michael Scott doing parkour, where we want, again, smooth, powerful, precise movements. So understanding these pathways, when do we best utilize our biophysiologic agents? Well, the clinical practice guidelines, when you review all of the literature, it supports both use and non-use. And the need to understand the intention of utilization is paramount when you're choosing which modality to use and when to utilize it. Additionally, these don't necessarily equal passive treatment. It doesn't mean that you're just putting something on them and then walking away. It means that for a lot of these biophysical agents, that your patients are an active participant within the care as well. And again, I'll be providing examples of that as we go through. So again, if we go back to the page article, there's a really wonderful recommendation list of each type of treatment modality, biophysical agent, and the evidence grade for each pathology, right? And there's really few A's on there of good, strong, quality evidence out there. And this is for a multitude of reasons. One, the randomization within these pathologies, as well as the different treatment parameters per device, as well as each individual clinician application of these modalities can vary greatly. But I just want to highlight the fact that, just the few A's for what we have are just like, just like electrotherapy for like knee ACLs, as well as, say ultrasound for ankle sprains. So I just want to highlight that a lot of this literature that's out there is kind of varying, for support for or against. But as you really start to dive through all the literature in which I've come through, so much, it's really hard to kind of extrapolate these from like a large meta-analysis standpoint. So as you understand that it's like, hey, it's not just stim for the knee. It's like, hey, like for an ACL, like all my ACLs, like post-op, like day one, are getting started on stim because I want them trying to get as large of an involuntary quad contraction as possible so that they're going to have as minimal of quad atrophy. And that's going to make my job easier for the long term, as an example. So as we start to go through these specific modalities one by one, I just want to speak to the fact is first, like, what is the mechanism of what it's using? And again, going through what is the intention of using it for a specific pathology. So TENS, delivers a mild electrical pulse through the skin. It stimulates sensory nerves, and if it's strong enough, then it's also going to stimulate motor units as well. It reduces pain through that ascending pathway by blocking pain signals from reaching the brain at the A beta, A delta, and the C afferent fibers, as well as the descending pathway. So it's triggering the body to release the endorphins and the A delta and the C fibers. And potentially is going to influence blood circulation as well. And so we put the electrodes on the skin at areas of tissue irritation, specifically that like of like a muscle spasm, right? So I think, patients that have back spasms, right, this can feel really nourishing on because it's like a mini massage within that area that is truly spastic. It uses an electrical pulse, right, to stimulate that, and through that it kind of signals the body to relax at a local level and at a global level to release some endorphins. But there are different frequencies for different units. There's different wavelengths on different units. And again, everything varies. So part of this is understanding first, is this indicated for a patient or not? That indication would be pain, perhaps spasm. What stage would this be best indicated? Perhaps the earlier stages, of an injury. But remembering the entire time throughout utilization of this is that the modulation of pain is not necessarily treating the cause of the pain. So, in the example of back pain, like if somebody has a herniated disc, like this isn't going to fix a herniated disc, but it's going to help somebody feel better and move better so that they aren't going to get stuck like in like a strong, like sympathetic tone, like pain state. And at the very least, it'll help them be more functional and be able to kind of like work with the injury more so than being than having to submit to it. Now, a different kind of electric stimulation is what we utilize more in the context of like post-ops, which is neuromuscular electrical stimulation. The intention is to utilize muscle activation on inhibited or weak musculature, Or on the other end of it, like you, from a recovery standpoint, just to get an involuntary contraction of the muscle to work as like a bit of a lymphatic pump. 10 to 20 minutes of duration of this voluntary muscle contraction. And you put the pads on and you increase the intensity as adaptation occurs, because your body will get used to it, and will start to recruit a little bit more from its diminished motor neuron pool. As that time goes on, essentially you're trying to get as strong of a contraction as possible. And there's good studies that show that the higher the contraction is that somebody can tolerate, the larger the motor unit recruitment is. And from there, then the reduced atrophy of that muscle. Or from a performance standpoint, from a recovery side, like, hey, if you're grabbing more motor units, you're going to get a greater, kind of lymphatic pump through that musculature, right? And this is just a real-time example of just a post-op, patient like 1 week out with the pads on the quads. And as that cycles on and off, as we have an on time of 5 seconds and off time of 5 seconds on this specific unit's preset functions, you'll get a nice strong contraction, right? And then you'll see it go flaccid, right? And we'll start with that from an involuntary contraction standpoint, where we'll just have the pads kind of pump the system, and then I will actively have them utilize that as well at different angles of knee flexion. As the closer that I can get them to like 60 to 90 degrees of knee flexion with this on, with them being able to tolerate it, then the higher the muscle activation and that peak torque recruitment of the quads come through. This also helps from the arthrogenic muscle inhibition effect, where essentially when there's swelling within the joint, that increased pressure causes a sensory receptor change that drives neural inhibition by altering the sensory feedback from the sensory cortex. Again, you go back to that slide before, you're processing the information bottom to top, back to front, and you want to have a nice, clean sensory input to allow a nice, clean motor output. So by stimulating the muscle like this, you're essentially bypassing that protection mechanism, and you're going to increase your muscular output. Again, it's going to help to flush out some of that edema and effusion within the joint as well. And I think that's why, the strongest evidence that's there that supports this use is within a post-operative standpoint. But what I would also say is like, hey, those really irritated knees, those like strongly effused knees, like grade 2 MCLs, ski injuries, like the patellis like subluxations, this will work really, really well to help to mitigate and to dampen that inhibition effect. But a cool part of what I discovered while kind of combing through the literature as well is that there's also this really strong physiologic and metabolic response that's occurring alongside this kind of this neuromuscular response. And great article that kind of looked at this through the lens of more chronic diseases that went through all of these metabolic markers and hormonal releases that's occurring as you have a larger contraction of the musculature. And I think you can kind of extrapolate this out, even larger within this patient population, that, well, movement and exercise is medicine in and of itself, but perhaps for them, if they can't access that for whatever reason, that perhaps here's something that we can mitigate that for within the short term. So again, that they're getting some of those, metabolic and hormonal markers that will help them get some skeletal muscle hypertrophy and have anti-inflammatory effects of this. So within the literature, yes, it is quite effective for the knee. For the shoulder, though, what about that? Yes, there's some great literature that supports that. But again, within more of a total shoulder standpoint. So again, that's probably most likely effective because it is you're stimulating this and it's affecting the joint itself so that the AGI aspect is being mitigated. But what about the back? Well, for this specific kind of stim, the neuromuscular electric stimulation probably isn't any more effective than exercise itself. And some of that might be due to just more like global inhibition that occurs in those times, or perhaps it could just be the intention where it's like, hey, like maybe we aren't necessarily addressing the effectiveness of like a swollen joint that is here. Whereas for the back, specifically the TENS units, where you're working on the getting the muscle to relax versus to contract, it is going to be more effective. So moving on to cryotherapy now, as I have patients ask me this question all day, every single day. So first we need to set up some parameters that not all cryotherapy is the same. Ice is not necessarily ice. And when we're talking about that, you know, are we talking about cold water immersion? Are we talking about whole body immersion, like a full ice bath? Are we talking about just like an ice pack in an application, or like other, like, you know, the phase change material where you're keeping that on your body, you know, for like 2 to 3 hours, although it's not as cold. And so ultimately, the intention behind this is analgesia, right? So decrease the perception of pain through vasoconstriction, right? When would we utilize that? Well, you could utilize that, you know, post exercise, you know, or you know, after injury when there's like a true structural damage standpoint. But again, need to clarify like what we're talking about from a cryotherapy standpoint. So that whole body, you know, a contrast immersion, where you're going in, you know, to the cold baths 2 to 4 minutes, versus, you know, just immersing, you know, that limb within cold water would be 10 to 15, or an ice pack around like 20 minutes. Those are the traditional cryotherapy models. But the phase change materials are actually like a bit warmer. So it's about 15 degrees Celsius, but again, you're wearing it for a longer amount of time, with the intention being that that's not ice. It's actually a lot of it is oftentimes like a thermal agent that's kind of mixed with like coconut oil, so that it does it does hit a freezing temperature, but the temperature gradient isn't as large when it hits the skin. And the thought is that it's able to kind of transmit deeper into the muscle itself versus getting stuck in more the periphery of the skin and the capillaries. And when you put all of these three things like head to head to head, it's like, well, like maybe it helps with some soreness, maybe it helps from a recovery standpoint. But again, what I find the most interesting is that the phase change material, like it has been shown, like with repeated literature, that it helps from a strength recovery standpoint. And there's some cool literature coming out within rugby and Gaelic football, specifically around this, where their players are putting these on like post match, like around their quads or their hamstrings. And I think some early data is suggesting that they're having lower risks of hammy strains as well, which is quite interesting. So we go through the pros and the cons on this, right? Lots of literature that supports the pros, right? Ultimately, you know, from a quote standpoint, you know, until the evidence is unanimously proving otherwise, the culture of icing injuries is probably going to remain a staple in sports medicine. With that, we should take on the fact that it's based on injury timeline and the repair process. 20 to 30 minutes, you know, within the first 12 hours of post-injury, again, is what's suggested within this body of literature. And if you need somebody to look towards on this, Susan Kirsten and Mel McHugh and their group at NISMAT have done some really great review research and really framing this from a kind of history standpoint as to why did we start doing ice in the way that we did initially, and how are we evolving that to now in the modern day, as there are some legitimate arguments to that. Well, if ice is stopping, reducing, and controlling inflammation, should it? because the vasoconstriction potentially could reduce, those helpful inflammatory markers like IGF-1 macrophages. And maybe it's actually causing a reduction of strength, not improving it, like what the phase change material is. So all things to take into consideration. I think, educating patients away from the traditional passive rice model and moving them towards that peace and love, you can tell that there's not necessarily, the ice as being part of that. I think that's definitely reasonable, but I think alongside that, it's balancing that with the analgesic effect of like, hey, if you're in a lot of pain, what is a non-pharmaceutical agent that is not necessarily, going to necessarily have long-term detriment if utilized appropriately and with clear intention. But what about when we use ice with compression therapy? You'll see these in training rooms a lot. The Game Ready is probably the most popular and name brand unit. And when you go to the Game Ready website, there's a lot of benefits that they say. Maybe it facilitates a decrease in patient opioid consumption. That's great. Perhaps it integrates, the cold and compression to reduce pain and edema, outperforming the rice model. It might improve patient satisfaction. Maybe that's the placebo effect. But if they're showing early discharge, from the hospital when utilizing it, and if it's showing like lower post-op blood loss, I think you can make an argument that, hey, this can definitely be something to be utilized within those earlier stages, is it especially to mitigate any excessive inflammatory responses, like within the situations of like a strong trauma or surgery. Within the thermo scans that Game Ready has published, they're showing it's like, hey, like we'll get the tissue down to like, about 5 degrees Celsius, where like, just gel packs or something else are going to have, maybe about 10 degrees different. But when you look at cryocompression within the literature itself, randomize, you know, essentially from a longer term standpoint, regardless as to what you're using, there's going to be some kind of benefit in the joint range of motion, your trophic changes, pain and function. But perhaps, this will show like a faster improvement within knee flexion, faster reduction of swelling, which is definitely meaningful, especially from a centralized standpoint. But from a function standpoint as well, where their walking distance, was significantly better for these, which you can make an argument is having a more important systemic health standpoint. But for every article that shows, that there's some benefit, you can find one that basically shows there's no difference between groups. When do I use this? I utilize it within more of my, truly acute, patients that have like a lot of effusion, like 2+, 1+, 2+ effusion. This will work really well, and I think it's largely more not so much from the ice standpoint. I think it's more from the compression standpoint. But when you extrapolate this out from a performance standpoint, it basically this could have like a negative effect, right? So utilizing the ice and the compression, right, from a performance standpoint in elite academy footballers, basically summarize that, hey, like if there's a neuromuscular mechanism that are required immediately in the short term of using this, like playing in a football game, yeah, it's probably not going to be the best thing for it. So again, utilizing this kind of more from a like a triage or from a symptomatic standpoint, certainly, there's strong argument for utilizing it from a performance standpoint, not so much. So when we take the ice out of it and we just look at the, as an intermittent like pneumatic compression device or like Normatec, you're essentially getting a similar benefit to it as you're removing the metabolic byproducts, you're improving circulation. There was a study that showed that the blood flow within the popliteal artery increased by 402%, which just is a crazy number to me. But I think regardless, it's pretty clear that's like, okay, like it's improving blood flow. It's also going to help to reduce the swelling, and as they say on their website, leads to faster recovery times and enhanced performance. But when you go through the literature, I couldn't find one that necessarily supported those claims. So when we look on the other end of this, right, again, what patients are asking me for all the time are, well, what about heat? Well, we just talked so much about cold. What about heat? It's like, well, you look through these meta-analysis, yeah, it is going to help you within the short term, right? That's the intention. Short-term pain relief, but alongside that, how is that going to impact your quality of life? And perhaps some mitigating stiffness. But when you compare these things head to head of heat versus like a sham treatment or a heat versus something else, across the board there's a greater amount of pain relief, and also positive benefits as far as tissue stiffness. So again, if somebody's coming in with pain or spasm, certainly in these acute stages, something that can be very helpful to mitigate this. But perhaps from a longer term standpoint, not anything that's going to be super meaningful from a long term standpoint. I like to think of all these things or what are ways to kind of unlock the door for the path that these patients need to get on to be able to exercise and to be able to move in the way that they want to move. When we put heat versus cold, really no statistical difference at all between pain, physical function, disability, or quality of life, which is really interesting. And so when patients come in and they're like, I don't know what to do, heat or cold, understanding like what the acute tissue timelines are, then ultimately my advice to them is like, hey, like what feels better for you and for your body, and the majority of them are able to kind of resonate with that. And if they aren't, I encourage them to try one or the other and compare those head to head. They will have a benefit for it. But as we start to look through these things, that go head to head, there is a small difference in strength with the heat versus cold. With the cold having like a slightly less standpoint there. So all things to take into consideration. Now, as we start to look at things that are more clinician-based treatments, ways that not so much that a machine is providing this specifically an application onto a patient, but perhaps how a clinician is applying this to the patient itself. And there's different kinds of instrument-assisted soft tissue mobilizations. They fall into this large category of IASTM. Graston is probably the name brand, but there's Gua Sha, there's the Hawkeyes, there's Rock Blades, tons of name brands that are out there. But essentially, the intention is that you're getting some kind of fascial lift to increase your blood flow, you stimulate some kind of lymphatic response, and you're reducing pain throughout the pain gate theory. As you look through these meta-analyses, there's with moderate certainty that it's going to reduce pain when you utilize this appropriately, but a low certainty that it's going to improve function. The mitigating factor on that, however, is that the intensity and the application matters and varies greatly between clinician. So the amount of force that I'm placing within a patient is significantly different than what one of my colleagues would be, and that's going to directly impact the outcome of it. So when you have patients come in and say, it's like, hey, like I got Graston, it didn't work for me, that's a great question to ask. And they're like, hey, what was the pressure? Were you in pain when that happened? Because if you were, that was probably too much, right? And so when I'm talking about that, I'm saying like, hey, like, you don't want to have like this very large, like erythemus, like ecchymotic response, right? You want something that's gonna be creating like a lift and stimulating these more superficial tissues, more so than trying to like go super deep tissue with it, right? That's what you're going for. And a lot of that is kind of based off of of cupping as well, and I'm a huge fan of cupping, as I feel like it gets like a larger fascial lift and like a larger contact area. So you end up stimulating not just like a larger section of the fascia, you end up increasing blood flow and lymphatic stimulation at a larger standpoint. But again, the application of that certainly matters as well. Not all cupping is the same. And I think we were all exposed to Michael Phelps's, like fire cup marks on his shoulders during the Olympics. And I think that's what everybody kind of strives towards. But the dynamic cups or the gliding cups is a very similar technique as to what the Graston techniques are, where you're just putting some lotion on and then you're sliding and you're gliding that, and you're trying to again lift these layers of tissue, specifically that of the fascia, so that they can slide and glide better. And then as such, you're stimulating that increased blood flow and then that lymphatic stimulation. Here's a video here of a technique that I'm using. Again, it's very gentle, it's very easy, and we can utilize that on a lot of different body parts with a lot of different, on a lot of different size cups that are there. But again, why does this work? Well, part of it's that pain gate theory standpoint, but there's also some immunomodulation effects, which I think are pretty cool, as well as some blood detoxification, as well as the anti-inflammatory and increased blood circulation effects through the nitric oxide theory. So I think this just encapsulates just a lot of different aspects of treating tissue both locally as well as getting a strong metabolic response, which I think is pretty cool and can be really effective. And I would share as well anecdotally that most patients tend to have a higher tolerance to this. So the total treatment time tends to be a little bit longer, which can also kind of help to get you to the point of the minimal therapeutic effect. Alongside that, we can utilize dry needling as well, with the intention of easing joints and muscle pain, loosening stiff muscles, and increasing range and flexibility. It also helps to promote that healthy blood flow and improve oxygen circulation. So a lot of the same benefits as to what we were just sharing with the cupping, just where we're utilizing just a single needle to hit to different layers of the tissue with the intention that you're stimulating the muscle itself, right? It's different than acupuncture in the sense that you're putting a single needle in to a specific spot of the muscle. And essentially, thinking of it as like, hey, like if you have like a knot or like a spasm of that muscle, you're trying to get in, you're trying to get into that like that knot, so that you're getting that tissue just to release and to soften. Versus acupuncture, which is such a beautiful and ancient modality that's utilizing various layers of energetic meridians and utilizing a whole body approach to it. Dry needling is certainly a less eloquent, like more of a specific muscular approach. And so when we review that literature specific for dry needling, we can see that there's a need for more constant parameter studies, as different certification schools are teaching this slightly different, as well as the total amount of time that the dry needle should be in. Perhaps it's a few seconds, some have it up to a few minutes. And again, what's the intention of doing that as like something that is going to be driving a little more sympathetic tone as there's a needle that's going in? It could be anywhere, up to 2 minutes. But there's been some studies that show that leaving it in up to like 20 minutes or so actually creates like a more of a parasympathetic rebound in a much larger response of relaxation. Moving on to red light therapy, lasers. Again, the intention of this is to modulate the cellular metabolism at the tissue, decrease inflammation, and ultimately, help for more of the surface level, with wound healing. But there's also a thought that it helps for more from the athletic exertion and recovery standpoint, because you're utilizing these little wavelengths of light that are absorbed by your cytochrome C oxidase that help to increase your ATP production and essentially have anti-inflammatory and enhanced blood flow effects. However, there is some questionable utility around accelerating repair of these deeper layers of structures within the setting of an acute or subacute injury. So an example of this might be something like a true like bruise, like contusion, right? Versus something that would be like a bone bruise, right? Like something that's more superficial, a cut, a scrape, like a ligament sprain, something that could be on the more superficial side. Certainly far more effective. And what about performance? Well, there's actually strong support for this, from a preconditioning standpoint. Essentially, like seeing that this is, you're essentially increasing your blood flow to prepare you for an event that you're about to do, which in turn can also help from an exertional standpoint and recovery. There's also been some suggestion that there might be more quicker return to play times for athletes by mitigating, the fatigue through the metabolic waste and strain. So perhaps the consistency of this training and performance can be more meaningful. The last modality we're going to talk about is blood flow restriction therapy. It's a class 1 medical device. We utilize a tourniquet on a proximal limb that's essentially measures your blood pressure. It decides what a full tourniquet pressure, a full atrial blockage would be, and then it backs off to about 80% of that. So that way you have full venous blood flow occlusion and you have partial atrial occlusion. And by that, it creates and accelerates a hypoxic environment and muscle fatigue. And fundamentally, it reduces the workload needed to reach the point of fatigue and failure. And utilizing this, again, within the context of somebody who is load intolerant, like somebody who has like a really hot Achilles, like tendinopathy, you can still challenge them to the point of fatigue. You can still challenge them, to failure. My post-ops love it because they feel like they're doing something like really like exertional, like a CrossFit or a HIIT workout when they're within, the first 2 to 4 weeks, post-operatively. And the reason for this is that it's not a mechanical overload, it's more of a physiologic overload. And that creates an accumulation of lactate, growth hormone, and IGF. And this can have both local and systemic effects at the muscular, cardiovascular, bone, and even and tendon, standpoint. But considerations to have is that, again, hey, what's your patient selection? When are you going to use this? Because there's no true difference between BFR and doing high intensity training by itself. So if you have somebody who is loading intolerant, again, like a hot tendinopathy, plantar fascia, somebody who is post-op, this is beautiful to use in these early to mid stages. But in the late stages, there's no difference between this and HIIT training. Right?
You're on.
So this is what it looks like. We've got the cuff on. It's how it starts. And then as you fatigue out, right, the form starts to go. So we need to be really mindful as to what that fatigue point is when we're utilizing this, right? There's different kinds of units. What we utilize at UW is the Owens Recovery Science units. There's also home units of Cat2 bands and the Smart Tools. The Smart Tools ones I think are down to like 250, and you can get those from an HSA standpoint too. So if I have patients who are really craving them, then that's something that I can definitely encourage them to purchase. There's a discoloration effect that does occur because you are in a hypoxic environment, and sometimes patients get freaked out, right first left. So that's something that I always like to inform them of before we start to do. And again, just like what I said, what the literature is supporting is that there's really no difference between BFR and high intensity training when you compare them head to head. But where this is most effective is when you're utilizing that before you can get to those max exertional standpoints. And when you compare just like the low load training of BFR against just low load training by itself, BFR is superior to that. So it may act as a surrogate for the heavier load strength training. So putting it all together now as we're wrapping up, this is my same post-op patient. They're like 1 week out. They came in, I started with some manual work, utilizing some cupping along the quad, along the hamstring and the calf. And then they were having some ankle pain as well. So I utilized some Graston just to create a little skin lift just on the front of the joint to just be able to help to facilitate more dorsiflexion with them. Alongside that, I asked them to contract their quad, right? You can kind of see it's a poor quad contraction. And then when we put the stim unit on from an involuntary standpoint, we got like a really nice strong contraction. And then once we paired with that, then we loaded them up. And again, from the same load and response theory, right? I'm utilizing this here. They came in post-op, they just had a little bit less capacity. Essentially, I wanted to get them over, on that curve so that then I could be more effective and more efficient with my therapeutic exercise challenge, because they need that in order to create muscle hypertrophy and in order for that to get them stronger and back to all their goals, right? If we look at the Tim Gabbert model, right, as to when we should be utilizing this, and this is probably the cleanest, slide I've ever found as far as like what, tissue load and response should be, right? We can use, the modalities here at the point where there's a negative response, at the point we're adjusting the program, or at the point when we're loading again. And again, it's the intention here. We could use, TENS for pain modulation here. We could be using, some laser or some Normatec here, within that mid stage, or as they're loading again, perhaps we're utilizing BFR to create more of a physiologic load, more so than that mechanical load that created a negative response. So in summary, again, like these are non-pharmaceutical short-term pain relief tools, right? The intention is utilizing these to get back to moving and loading as quickly as possible. And when we break them down as far as like a short-term, mid-term, and long-term, intention, uh, the short term is like the TENS, heat, cold, NMES. Your midterm is more your BFR, the game ready, and the cupping and stim. And that the a lump category from a long-term standpoint, as far as the recovery tools, the Normatec, laser, and perhaps cold. And I have that same chart there on the side, as well as specific pathologies and the grade of evidence that's there for that was from that page article. So hopefully I didn't put you to sleep. And thank you. Any questions?
Thanks, Dr. Geller. That was awesome. I think, with the fellows on right now, the amount of times I get patients asking me where or what exactly modalities are, or what they find, useful, or come into clinic and like, yeah, I got Graston, and I don't know what that is honestly like on a daily basis. So I think just understanding these things from y'all's side of things and what you do on a day-to-day basis is helpful to learn and understand. One of the questions was regarding like buying these modalities, like over the counter type stuff, and how you kind of counsel patients on their safety and efficacy regarding like these things that you can just buy over the counter.
That's such a great question, because I've had patients come in with like refurbished units that have definitely been like a primary like pain driver on that. So I will, ask them if they have a unit and they're unsure. I'll ask them to bring it in first, and then we'll kind of explore and vet that, and I'll kind of do my own research. But essentially, the majority of the legitimate companies are going to be FSA or HSA approved. And that tends to be like a good starting point of being like, hey, has this been vetted through some kind of agency first? Are these hitting the therapeutic parameters in which they're marketing themselves as? But always, and most importantly, what's the intention behind doing this? And is it providing you pain relief? Because all of patients come in and be like, oh yeah, like I'm using it. I'm like, cool. Like, is it helping? They're like, I don't know. I'm like, well, then it's probably not.
Absolutely. No, that's a good point. I didn't know that once they're at HSA, FSA approved, then they're kind of the third party tested. So that's good. Um, if anybody wants to reach out to me or uh, anybody through AMSSM about any questions, and I'll happy to relay those to Dr. Gellert and get back to you guys. But thank you again, Dr. Gellert. This was great. Appreciate your time and educating us on this important topic.
Yeah, awesome. Thank you for having me again. It's been an honor. So thank you.